So thank you all for being here. We are very excited to have Dr. Barbara Chaiyachati, who is joining us today to discuss her work. Dr. Chaiyachati is a physician scientist with a PhD in cellular biology and an MD from Yale School of Medicine. And she completed both her residency and fellowship here at CHOP, where she is now an assistant professor of pediatrics. Dr. Chaiyachati's research focuses on addressing the short and long-term effects of traumatic stressors and adversity that occurs during childhood. And her work integrates a number of translational approaches, so spanning genetics, epigenetics, and population health, with the goal of improving outcomes for vulnerable groups. Her research also addresses other critical issues, including healthcare disparities, the opioid epidemic, and social determinants of health, areas that I know align with many of our own research interests. So I know we're all looking forward to this talk. So please welcome Dr. Barbara Chaiyachati.
Thank you all so much for having me. I am excited to share with you today some of the work that I have been able to do and some of the projects I'm currently invested in, and really hope that today might serve as the start of some more conversations about ways that we can be integrated across the Children's Hospital and Penn and all of the amazing research that is at hand. So, some disclosures, just that I have some funding, but no off-label uses of any medications. And then there's, I think, one slide that I included that comes from this federal resource of the Child Welfare Training Toolkit put together by the National Center on Substance Abuse and Child Welfare. And that I was not a part of making that. And so the acknowledgement for that work is here. Moreover, I have a big slide at the end, but I definitely want to start with gratitude just in case I end up getting caught up and don't have enough time at the end to recognize that the work that I am presenting today is built in collaboration with many people, including my community, friends, and family. And then finally, my last disclosure before we get to the meat of it, is to give and receive grace. There are a lot of stressors and pressures active in our world, in our community, and in full disclosure, in my house right now with a febrile toddler downstairs. So I will do my best to be here and be present with you guys today, and will receive with full grace any tips and tricks to better communicate in the future. Moreover, one other point of making sure you guys give yourselves grace is that while you all are very accustomed to talking about addiction and substance use, an additional point of work that I participate in is with regards to childhood trauma and child abuse. And so just naming that in advance in order to make sure that everyone sort of takes that space if needed as we progress. Okay. And so with that, ACEs, adverse childhood experiences, comments or an idea that we all are very familiar with, I'm certain. And this landmark study by Vince Folletti and colleagues as of 1 o'clock today has been cited 24,980 times. So maybe it broke 25K in the last couple hours, and clearly spoke to the scientific truth that early life experiences affect and seem to be associated with long-term health outcomes, even when we don't see a direct connection between the two ends of the string. And not only reflected within the scientific literature with those thousands upon thousands of citations, but this has also very much been taken into pop culture science from NPR, New York Times, Time Magazine. ACEs are absolutely something that can often be used in shorthand, even in dinner table conversations with people who are not medical researchers. And yet, this and I start here because this was the world in which I started my career as a physician scientist. And so I am with you today and partake in this work in order to make progress towards my personal and professional mission to improve the health and well-being of children by understanding the early physical and emotional trajectories, health trajectories after adversities. But these things that happen to children do not happen in isolation. They happen within an ecosystem that encompasses family, community, and society. And here at Chop and Pen, we are uniquely positioned to be able to look at these forces across levels. And I am so grateful for my colleagues, including those at Chop Clinical Futures and Chop Policy Lab, that allow me to, in collaboration with friends and colleagues at the Lifespan Brain Institute and the Center for Applied Genomics, go up and down the translational spectrum of research, thinking about how not only make those lived experiences become biologically embedded, but also how those things that happen within these larger ecosystems can continue to be analyzed and assessed to find points of action. And in my process of developing my mission, I hope to make progress towards this in three aims, and am currently, working on my career to do so. One, through the genetic susceptibility and biologic embedding. Two, by investigating in translational integration. And three, maintaining service to actionable targets for intervention as a physician scientist. The story I'm going to tell you today starts at point two, because we can never start at the beginning, but rather let's start in the middle with some translational integration. And so, as a researcher, as many of us are researchers, right? We start our study questions with all of our table one demographic variables. And so first, what is a demographic? The definition from, I believe, Merriam-Webster, somewhere on the internet, relating to the structure of populations. And we can all bring to mind our commonly used demographics, including race, ethnicity, gender, socioeconomic status, and age. And it's important to investigate these and interrogate their associations because we know that when we stratify populations by demographic groupings, including race and ethnicity, health outcomes may be different. And yet, and probably related to the ubiquitous nature of race and ethnicity within our population and within our lived experience, we think of race as being something that is defined and that separates a population into two clearly defined groups. However, I would argue that race is unlikely to be experienced the same when we're in a healthcare setting versus at home or in some other public avenue. This isn't just something that I have sort of percolated, right? There are many other people, but thinking about the data of this, the data that underpins this suggestion, is actually just looking at the census. So digging in from 2000 to 2010 in this working paper published by the National Bureau of Economics, the same prompt asked in the American Census from 2000 to 2010, when we look at the groupings at the total population, for example, of the population defined as or described as non-Hispanic white alone, it looks about the same, 124 million people with maybe 600,000 variation. However, when the study responses are actually drilled in and we look at the individual level, the data reveals that there is much more flux and churn both into and out of the category than what might be reflected by those end times of 2000 and 2010. And so while there's only 600,000 between those two big numbers, it actually is 2 million people who left the category and 1.4 million people who entered, which for that population group still reflects that 97% of people of actual bodies are the same across those two time points. For less frequent groups, that gray middle, that percent that stay in the category, is much, much smaller. So for example, for Native Hawaiian Pacific Islanders, the NHPI, only 48% of bodies are consistently described within this group across these two time points. Overall, that means that at the census level, 6% of bodies are changed categories from 2000 to 2010. And estimates suggest that the number is even higher for children. So upwards of 10% of children were categorized as different from across these two time points. Now, from a personal note, the 2020 census was my first time speaking for my partner and my children. And this brought to the front of my mind, beyond that researcher's mind of what is the data I'm working with, what are the table one figures that I need to know and count, but it brought to my mind, what is my role in describing the identities of my spouse and my children within this foundationally important gathering of information? And my household contributed to the increase in the multiracial percentages that were described in the 2020 census. So there's a 276% increase in the people identified as multiracial from 2010 to 2020. Some of that may be related to how the question was asked. Some of that may be related to true demographic shifts. Some of that may be related into how we are thinking about our own bodies and relating to the groups around us over time. Importantly, and I think critical, is that some other race was actually the second most common selection, alone or in combination, in terms of how people are identifying, reflecting that the categories that were used in the 2020 census did not reflect for many people how they felt was what the words would be best for them. And so I had the choose from the options below. I had the opportunity to develop with some colleagues some ideas and just percolations around how might we think about race and ethnicity data in our health research, recognizing that many of us build research questions upon secondary use of clinical data, which is so important and yet imperfect. And so in some of our musings about what is it like to be caregivers of multiracial children and also health scientists, researchers, these are some of the words we put together thinking about how if we can reflex to other, recognizing that any collection of small boxes will never equal the sum of their inherited legacies or gathered experiences, a critical acknowledgement as we seek to disentangle the drivers of disparate health outcomes. And so from that, we said we needed to work on increasing data transparency. And in order to increase our transparency, it would serve us all to look at the data upon which we are building our inquiries and review the assumptions, as well as disclose the details and decisions that we are making in the process of building our table ones. And that led me to do some more internal investigation and say, okay, how much is this actually relevant within the pediatric medical record system that I'm interfacing with as a clinician and primarily as a researcher? And so in this work that's now published in JAMA Peds, we were able to pull every race data point that had ever been collected in the CHOP medical record system. And we stratified this by encounter count, recognizing that encounter counts would reflect the number of times a person would be interacting with the healthcare system, which is obviously a very different phenomenon than just time or years covered with regards to how many opportunities a family or a caregiver has to interact with that registration process at which we are most commonly sort of thinking about how we are reflected in the medical record system. And so in many ways, very consistent with the census data in terms of overall likelihood of change. Overall, in the CHOP medical record system, 6.7% of records had some change from one category to another. And for those for those people in the medical record who had more than 16 encounters, it was up the total rate was 8.5%. And while the words may be hard to see in terms of which race group is within each row, the point of this is to say that it's not the same. That the likelihood or rate of people changing into or out of a group is not the same across race groups. And that this increases with the number of encounters or opportunities to change. And so the more times we ask the question, the more variability we will see in the data. The actual pairwise changes, the most common change was from people changing from other to white, but almost every other option is reflected. I think there's one connection in the circle that isn't connected, and I can't remember which one it is. But basically, every part of every piece of the category, every category option was represented in connection to almost every other piece. And to be clear, turns out this is in subsequent work, this is not just CHOP. So it is not just the census, it is not just CHOP. More papers and more work has come out. This is a paper that was published in JAMA Network Open last year, looking at data from Michigan, and that just across 2 encounters within emergency care, 1.7% of adults and 7% of pediatric records changed categories. In another study, which was a single moment of cross-reference where families were surveyed while their child was in the hospital, they found a 30% discordance or 69% agreement, so 31% disagreement for the category of race. And overall, there was more than 1 in 5 families conveyed that they felt that the medical record poorly described their children in terms of the categories or options that were available. This is work that I bring up because it is relevant to every NIH report that we have to put in when it comes to our study participants. We submit our data according to the OMB, the Office of Management and Budget numbers. And from 1997 to 2024, obviously a big change has come out. And so in March of last year, the SBD 15 was updated to change from the 2-question race and ethnicity to 1-question race and/or ethnicity, with some additional very important category shifts within that, including the addition of a category of Middle Eastern or North African. And within that SPD 15, it is expressly stated that for purposes, the race and ethnicity categories set forth are sociopolitical constructs and are not an attempt to define race and ethnicity biologically or genetically. Because race is a social construct, ethnicity is a social and cultural construct. And when we are sitting in this space of translational integration, when we are thinking about doing genetic studies and genomic studies, there are realities of linkage disequilibrium patterns that are unevenly distributed or differentially distributed across populations. And race and genetic similarity should not be used interchangeably, or it puts us at risk as researchers of reifying race as a social construct as having some biologic underpinnings. And so to push further from that data where I just looked at the race social construct sort of mappings within the medical record system, we then also looked at the genetic similarity populations and how they map or align with the social construct of race ethnicity options that are available within the EMR or enrollment survey. And so this is work that is ongoing. Overall, in broad strokes, I have a population of limited to those born after 1980. So looking at a current pediatric population from a large pediatric biorepository, the Center for Applied Genomics at CHOP with Hauken Haukenaarsen, representing approximately 65,000 samples. We have an enrollment survey that a caregiver completed when their child first entered into the system. We have the medical record because most of these or all of these children are children who have medical records within the CHOP system. And then we have a population, a genetic similarity grouping that reflects the PCA defined ancestry by MDS, with a total of in this analysis separating into five sort of continental ancestry genetic similarity groups. Now, in the process of of initiating this point of investigation, we came to the realization that we did not want to be the ones making choices about which groups aligned with which other groups. That I did not want to sit and have my category maps in front of me and say, this to this is the right choice, and this to this is the wrong choice. And so we actually developed a data-driven mapping structure in order to support that our population that is reflected within the collection of participants that we have was guiding its own sort of category mapping structure in order to be respectful to the population that is reflected, as well as be respectful of the time and context in which this data was gathered. Now, in order to do this, we always mapped from more category choices to fewer category choices. So if there were, 8 categories in the EMR and 12 in the survey, we always went from 12 to 8. So I did that direction opposite. Sorry, guys. Hope you're following. And in order to identify concordant or discordant, we then, from what was the most common choice or the most common destination, we just identified that as being the concordant option. What does that mean? That's a lot of words. So, for example, if we have 3 population groupings, group A, B, and C, in our first sort of population structure, and then we have this new choice architecture that only has 2 choices, choice 1 or choice 2, I don't know where these different bodies are going to go. Let's say that all of the solid blue circles go to category 1. Great. That is category A maps to 1, and so it's 100% concordant. Let's say the yellow stripy circles all go to 2, so that is similarly 100% concordant. On the other hand, if the blue stripies split their group into across categories 1 and 2, then we would name map destination 2 as being concordant, and we would describe the total population group of B as having 66% concordance. So built upon this, we part of the reason we did that is because when we actually looked at the data, when we actually looked at where bodies were going across these multiple choice architectures and mapping schemas, we saw this beautiful array in the middle that would require us to make a lot of decisions. And so again, we let the data guide us in terms of which ones of these would count as concordant or discordant. To be clear, I don't think there's a single right answer or a single wrong answer. I think people and bodies should be able to identify themselves in the ways that make the most sense. And yet, having consistency in some of the vocabulary we're using across studies is really important simultaneously to allow generalizability and reproducibility across time and setting and context. So, what are the results from this data? Well, overall, it's about 10%, of bodies have some discordance by this data-driven mapping. And by groups, it varies substantially. Overall, in our population, this is consistent with just the EMR data, or now we have this sort of multi-source data. For populations that have high frequency in our data samples, there is in general lower discordance. And on the other hand, for populations that have low frequency within our population, there is much higher variability or higher discordance. So for example, American Indian population that is represented within this sample, 95% of bodies had at least 1 point of discordance within these pairwise comparisons. To all of us in the group doing genetics or genomics work within this modern data, building upon publications within MVP, this data shows that even within, when we look at across the birth years from 1980 until 2020 and look at the likelihood of assignment to the population ancestry, the continental ancestry groups, that there is a statistically significant decline within the most frequent groups, as in the reference populations that we are that are often used to sort of say a body matches here or a body matches there. We are actively seeing within this data the deviation of populations from those reference. And so, given that population groupings are non-uniform, study-specific, and dynamic, how do we proceed? I think I am continuing to work to check my assumptions and evaluate with each study question at hand. So we often go into our work, I as well, thinking that the data in front of me is stable, relevant, and robust. And over the last several years of work, interrogating the demographics of race and ethnicity, I have seen even that these broad descriptors of stable, relevant, and robust are not always true. And so I think it is on all of us to continue to think about how can we evaluate and in what circumstances do we need to evaluate these? And the answer is with every study question, but really being willing and humble about the sort of best path forward. In all of our efforts, we need to continue to persistently evaluate conflation between biologic constructs and social constructs and be rigorous about what is the place of whatever it is within the conceptual model at hand. The National Academies put out 2 years ago um, a, a book around genetic population groupings. There's another text that has been released within the last year. Both provide a lot of really wonderful framework and discussion around all of us sort of doing best going forward. And this is important because without intentionality, medical studies risk falsely reifying the social construct of race as a biologic one. And so, with that in mind, I then am also thinking about how are these things? How do I take some of that we've just talked about from the big translational research sort of space and put that into the genetic susceptibility and biologic embedding? And so one of the pieces is looking at the PNC, which is the Philadelphia Neurodevelopmental Cohort. And in this work, it has been demonstrated that when children experience adversities, they have worse mental health. And this work has been demonstrated across multiple domains of behavioral health in adolescence. Moreover, and consistently, family history also affects adolescent behavioral health. And that has been captured within genetic signal of polygenic risk scores. But family history isn't only genetics. Family history is also environment. So back to the beginning when we talked about ACEs, family history is an ACE within the Folletti list. And family history can also act indirectly as an ACE. Family history of psychopathology can act indirectly as an ACE, potentially through mechanisms such as decreased monitoring. That decreased monitoring then may influence the likelihood of experiencing trauma. And so thinking about how do we tease apart and identify actionable paths between family history and trauma and adolescent psychopathology led us to really dig in and say, can we quantify this? Can we identify separately both the direct and indirect effects of trauma within the associations of family history and psychopathology? This work overall represents what I think of as some clinically sort of pragmatic and slightly simplified ways of thinking about family history. very simplified ways of thinking about family history. In terms of thinking about family history as a clinician, I would argue sort of putting me in the bucket of a simple clinician, as a simple clinician might think of it, much more simply than the finessed and really important heritability work, but really thinking about, okay, what is the burden of family history that this person is presenting in front of me? How much family history, how many different domains are affected? Additionally, thinking about traumas and the magnitude of traumas, but also just doing some simplified accounting. So counting of traumas, 0 through 3, and then thinking about factors such as age, gender, and for this study, separately collapsing categories of race to reflect race as a proxy for risk of experiencing racism. For the data as collected here, binarize that to people to in one of two categories, to be minoritized or not minoritized. And so for this conceptual model, the data strongly supports from ACEs to many, many other pieces of work that trauma is associated with adolescent psychopathology. And our first step was thinking about recognizing that we also all recognize family history is associated with adolescent psychopathology as well. And so how much of that path of family history to P factor is mediated through experiences of trauma? To do this, we built a structural equation model, and this suggests the VAF, for variance accounted for, suggests that approximately 20% of the effect is mediated by experiences of trauma. Trauma does not happen in isolation. So adding on neighborhood factors and thinking about how the neighborhood environment may associate with experiences of trauma. The effect is there. Neighborhood absolutely associates with experiences of trauma. It does not substantially decrease the magnitude that that trauma is mediating the association of family history and P factor. And finally, in a very simplified model or a very simplified approach, looking at a latent genetic factor that reflects a latent construct comprised of 5 polygenic scores for a collection of behavioral health disorders in adolescence. And this model, to be clear, is limited only to the bodies that mapped to the European genetic similarity construct. Overall, the variance accounted for is unchanged, even when we add in the latent polygenic scores. And so, in conclusion, more than 20% of family history association with adolescent general psychopathology seems to be mediated by experiences of trauma. And thinking about points of action, this raises a substantial question or opportunity within the disruption of intergenerational transmission of psychopathology to think about how the care of adults with undergoing any sort of behavioral health supports or interventions may be able to have more explicit conversations and interventions around decreasing the experiences of trauma or risks for trauma in that opportunity to disrupt intergenerational transmission. And finally, all of this is from a space of thinking about how, to that point, how can we keep an eye towards serviceable, actionable targets for intervention. And so I'm a clinician, and I'm actually trained as a child abuse pediatrician. But I'm here today, and I'm here, not but I'm here, and I'm here today speaking to colleagues and researchers in the space of addiction and substance use. And these are very much epidemiologically intertwined points of care. Substance exposure represents the most common or one of the most common risk factors within families within sort of the family histories of children who experience substantiated child abuse or neglect. In 2021, for example, that was 26% of maltreatment victims with caregiver substance use, another 15% of victims with caregiver alcohol misuse as an identified risk factor. As a society, from 2000 to 2017, this was reflected in a 147% absolute increase in foster care entry attributed to caregiver substance use. So in this graph from Meinhofer, JAMA Pediatrics, the top line represents total entries into foster care. And so while as a society, we have prioritized and made meaningful stabilization efforts when it comes to children who are experiencing out-of-home care as a population, that bottom line, entries owing to parental drug use, is increasing substantially. And so, while there is much discussion to be had about the forces and efforts at play that are reflected within that upward trend, it is evident that this represents an area of need. And so for me as a clinician in child abuse pediatrics, that is my motivation for being here and speaking with you guys today from a space of intersection with addiction and caregiver substance use. As a nation, this is a substantial issue in Philadelphia. Here is continued updated numbers from across the country. So parental alcohol or drug use as a condition associated with removal by state. So total on average for in 2021, 40% of children who experienced custody disruption was related to caregiver substance use. Now, not only do we know that's a national problem, we are all very well aware of the substantial issues of addiction, overdose, morbidity, and mortality within Philadelphia. This is the number of overdoses that have happened per year, increasing and potentially stabilizing within just the last couple years. 2022, 2023 data seem to be stabilizing around 1,400 fatalities or so. Now, just to put in mind, normally or often I also reference the number 514, which was the number of homicides that were experienced in Philadelphia in 2022. All of these represent avoidable loss of life that should be unacceptable. And we all need to continue to work together to reduce the mortality and morbidity from these epidemics of violence and substance use. And adult overdose is just one is one piece of the mortality. From a morbidity perspective, data supports that the infants born in Philadelphia affected by prenatal substance exposure, as demarcated by a diagnosis of neonatal abstinence syndrome, the curve closely aligns with that uptrend that we saw within the overdose fatalities. So while numbers have the reporting numbers are not available in the most recent years, we suspect that these numbers continue to reflect the substantial increase that our population experienced within the last several years. And so I have the opportunity to serve this population within a clinic called NFP RISE, which is the neonatal follow-up program, Resilience After Infant Substance Exposure. I bring this up as an opportunity to think about the integration of research, of policy, of advocacy, and of doing our best to serve families in the ways that they need to be served, informed by the population in which we live. We started this clinical care track in the summer of 2021. And within this clinic, we perform standardized neurodevelopmental evaluations in collaboration with PT, OT, social work, psychology, care navigation, and Care Connect Warm Line. doing what we can to address that intergenerational aspect, and very much recognizing and holding humility for the caregiver as being so important to the health and well-being of the infants in front of us. We do our best to provide recovery-informed care. From a pediatric vantage, what does that mean? As adults, adult providers, I'm not one of them, I hear talk about things like harm reduction, safer injection practices, naloxone. We talk about some of those things, but in a different way. Thinking about recovery-informed care and how to best support the safety of families affected by substance use, including families with very young infants, includes conversations about safe sleep, probably conversations that some of you, if you've had, young infants, have heard from your pediatrician of make sure, back to sleep is safest and the potential dangers of co-sleeping. We have those conversations as well, and informed and interactive with the realities of recovery, as well as, for example, the potential sort of dosing changes that adult bodies after pregnancy might need. So many people experience a need for increased doses of methadone during pregnancy associated with the physiologic changes. And then postpartum, bodies continue to change. But caregivers have conveyed that rarely is anyone talking about that intersection. Rarely is anyone talking about the intersection of how their recovery care is interacting with this incredibly new and important role that they have as a caregiver of a newborn. And so that is some of the content and space that we do our best to help support people in. Additionally, naloxone, if you don't have it, get some. And it's important to know, and as a pediatrician, I would be remiss to tell you, if I didn't tell you, God forbid, we would never want a child to have an exposure to an opioid. But if that does happen, naloxone is safe to give to children just as it is for adults. And we started with research. We'll sort of end with research. I do have the fortune of being able to integrate the work that I do within a variety of research studies and continue to be excited about potential collaborations going forward. And so, a little bit fast. I still have a couple minutes left for questions. I'm so grateful to be here and talk with all of you today. And I hope this has been a little bit informative with regards to why a child abuse pediatrician would be talking to you all. So thank you for your time, and I look forward to talking more.